Good evening. I'm deeply honored having I work at Yoido Center, and I'm a professor in of cerebral palsy, publishes in DMC and in
Okay, can you hear right now?
Yeah, we can hear.
Okay.
You can play from the beginning. Yeah.
in 2013. It has long been recognized that goal-directed training plays a critical role in rehabilitation therapy, and it is on the top of the list. In the early 2010s, robotic therapy was considered a part of assist technology, and its recommendation level was not particularly high. In the updated version published in 2020, there are no significant changes. However, with advancement in technology, you can see that the term robotics has been explicitly mentioned. As mentioned earlier, the key principle of rehabilitation medicine is task-specific and goal-directed training, and the training improves specific movement being practiced. Considering that muscle activation patterns in actual walking are clearly different from those in treadmill walking, it becomes evident that our ultimate focus should be on overground walking. Furthermore, restoring walking ability is very important. This study reports the relationship between the average daily step count and annual mortality rates, showing a dramatic decrease in mortality rate as the average daily step count increases. This means walking is indeed crucial. However, in actual clinical practice, it is challenging for caregivers to physically support patients and helping them work. In this regard, exoskeletal robot can help rehabilitation and caregivers. Among various types of lower limb exoskeleton, overground type is designed for walking on the ground, mimicking natural walking in real-life environment. It provides realistic and natural gait training and improves mobility and independence. Treadmill type utilizes a treadmill where a user practices walking with robotic assistance in a controlled environment. As advantages, it allows repetitive and stable training in a fixed space and facilitates load adjustment and gait pattern analysis. Also, it can include safety measures like a harness to prevent falls. In the end effector type, the robot is directly attached to the user's feet, guiding them through precise gait trajectories. Usually, it has simple design and easy maintenance, and it enables precise control of walking patterns. Among the various types of rehabilitation robots, I have believed for over a decade that the overground type would be better for lower limb rehabilitation robots. Accordingly, in 2017, I used the Exowork followed by the Chhabra from 2018 to 2020. And nowadays, starting in 2024, I have been using the EA2 Pro. As you can see, while their form differs slightly, they share the common feature of enabling overground gait training. The research demonstrating the effectiveness of robot-assisted gait training has been consistently reported since the late 2010s. This study from Japan reports the positive outcome of approximately 20 training sessions using the HAL system in subacute stroke patients. This study conducted in South Korea using Exowork. This research involved 20 sessions of 30-minute training and reported slightly better outcomes compared to conventional treatment. As shown in the image, the Exowork does not provide trunk support. Consequently, it cannot be used in the patient without a certain degree of trunk control. For this reason, this study was limited to patients who can stand alone. There is also research utilizing the EA series of Cosmo Robotics. This study was conducted at Korean University Hospital in South Korea. Similar to previous studies, 30-minute training were performed with a total of 12 sessions. The results showed significant improvement compared with conventional guided training by physical therapists. According to a recent systematic review published in 2024, robot-assisted gait training (RAGT) have a potential role in the recovery of walking dysfunction after stroke. However, when compared to conventional therapy, the differences are not substantial, indicating the need for further research to determine which treatment is superior. The interesting point is that, as I thought in the early 2010s, overground type are showing significant improving in the walking performance, and it looks like overground type may be superior to treadmill type. Including the E8 Pro, overground robot-assisted gait training are more closely resemble actual walking, as it allows walking forward. In subacute stroke patients, it is common to encounter patients whose trunk control is compromised, so it would be ideal if it includes a trunk support option. And when applying robotic systems, it is also essential to check for joint range of motion limitation or excessive spasticity to prevent the patient injury. What could be the mechanism behind the positive outcome of overground type robot-assisted gait training? I believe there are three mechanisms at play. First, it aligns well with the rehabilitation principle of task-specific training. When you practice, the specific movement you practice improves. Second, it improves cardiovascular fitness. In rehabilitation therapy, even maintaining a standing posture can yield a positive effect. Third, patients tend to find it more enjoyable and are more likely to actively participate in the therapy. Rehabilitation robots often make patients stand for 20 to 30 minutes, which can be more tiring than expected. This is something to watch out for, especially with subacute stroke patients, because it can cause syncope or hypotension. What is clear is that robot-assisted gait training goes beyond the simple effect of tilting, and it can offer the next level of rehabilitation. During the past 10 years of applying robotic therapy, I have two cases of patient syncope. Both incidents occurs in elderly people with subacute stroke. Except those, these type of robot therapy are effective and safe tools for rehabilitation. In some cases, therapists have to continuously support the patient, which can be more physically demanding than expected. So, what will the future of powered robotic lower limb exoskeleton look like? Since the technology is already well developed, the key will be how this technology can be integrated with other fields. In my opinion, the first is the integration with AI. This study was published by our research team in 2020. We processed the biodata with AI to simulate instructions similar to those given by therapists to patients. We selected 6 common instructions given by therapists and trained the AI to understand the situation in which these instructions are typically made. As a result, we were able to develop an AI system that delivers instruction with nearly 90% of similarity to those provided by actual therapists.
아주 잘하고 있습니다.
아주 잘하고 있습니다 means great.
상체 세우세요.
상체 세우세요 means pull up your trunk.
오른쪽 다리 긴장 푸세요.
오른쪽 다리 긴장 푸세요 means relax your right leg.
아주 잘하고 있습니다.
That means great.
아주 잘하고 있습니다.
So we give positive feedback to the patient. At the end of therapy session, the AI generates a report on performance metrics such as bug balance tests and so on, which based on the therapy data. And this system improves the compliance of patient, and also this kind of system has the potential to be expanded for the use in telemedicine. This is another paper related to AI published in our research team in 2021. How intensely should we apply rehabilitation robot? Patient may require training at various levels of complexity, ranging from standing practice on tilted table to more advanced tasks such as climbing stairs. What type of training should be prescribed? As briefly mentioned earlier, particularly in subacute stroke patients, unstable vital sign can pose challenges during robotic therapy. Prescribe appropriate exercise is a key concern for many physicians. Our research team utilized various measures such as a functional scale like modified Vassell index and functional ambulatory category, as well as blood chemistry results including CRP, cholesterol, and lymphocyte level, and so on, to propose the most suitable AI model for determining the appropriate level of exercise. Second is integration with functional electrical stimulation. This paper published in the New England Journal of Medicine in 2018 caused quite a sensation in the academic community. I also personally found very interesting to read. In fact, this system operates in a classical manner, not by moving the legs through the individual muscle controlled by electrical stimulation, but by increasing sensory input to induce motor output. As you may know, motor control in the spinal cord is determined by the amount of input that reaches motor neurons. Our nervous system functions as a sort of biocomputer, processing sensory input and generating appropriate motor output. As in this study, increasing sensory input through electrical stimulation and generating meaningful motor output from it requires an intact spinal circuit. This mechanism is also why the study focused on specifically individuals with high spinal cord injury between the C4 and T4 level. This study is one I published last year. I conducted the research out of curiosity about how much output could be elicited from individual muscle using electrical stimulation. The results showed that the muscle output achievable through electrical stimulation was about 20% of maximal voluntary contraction. Therefore, I anticipate that in the future, the remaining 80% will be compensated by exoskeleton robot, and AI will be integrated into the system. In summary, robot-assisted training might have a potential role in the recovery of walking dysfunction after stroke, and also in spinal cord injury, especially overground RAGT may be superior to treadmill RAGT. Considering the pace of technological advancement, the future of RAGT is promising, with expectation for integration with various fields such as AI and FES. In 2018, I spent a year as a visiting professor at Stanford University. More recently, I have had the opportunity to collaborate in workshop with professors from Johns Hopkins Hospital and Mount Sinai Hospital in New York and Mountain View Hospital in Las Vegas. I sincerely hope to continue connecting with many physicians who share an interest with rehabilitation robotics. Thank you for listening. Wishing you a wonderful new year. Dhanyavad.
Thank you, Professor.
Thank you.
That was,
Thank you for listening. Yeah.
yeah, that was a great presentation. We'll take any questions from the participants. You may either write the questions in the chat box or you may ask them directly to Professor.
I have one question.
Yeah.
Right.
In one of the studies, so you mentioned that when you, out of curiosity, when you observe that 20% of MVC was there with electrical stimulation, and then you're planning that 80% of that would be covered using some robotic technique combined with the AI. But actually, during walking or while walking, we don't use 100% of MVC. So we probably don't need to have the 80% of the contraction from the robotic part.
Yeah,
So
exactly. Yeah, I agree with your opinion, and it's theoretically, yeah, proposed description. So, yeah, we don't need 100% of maximal voluntary contraction during the gait. Yes, so it is account the future direction of our development.
yeah, okay.
Sir, I have one question. Can I
Yeah.
ask one question, sir?
Yeah, please.
Yeah.
Please
Forget
introduce
these
yourself.
conditions.
Please
Yes, sir.
Yeah, please briefly introduce yourself and then ask the question.
Sir, I'm Dr. Binish Balakrishnan. I'm working at Hamsa Rehab, Chennai.
Right.
I'm a rehab physician. I have a doubt about other uses for robotics, according to you, other than stroke, spinal cord injury, traumatic brain injury. Do you see it useful in other conditions?
Can you ask me once again?
Other than spinal cord injury, stroke, and traumatic brain injury, do you see exoskeletal robotics helping out with other health conditions?
Yeah,
Extremely
course.
fatigued patients.
Yeah, nowadays,
let's say cancer rehab patients with extreme fatigue.
Yeah, exactly. And nowadays we are trying to expand the indication of rehabilitation robots. So now I'm under the study about post-orthopedic surgery, such as TKRA or THRA surgery, to help them their recovery and their gait. And also, I think, yeah, I agree with we can apply this robotics to the cancer patient or another sarcopenic patient in old people. Yes, I agree with that.
Thank you very much. Thank you.
Yeah.
So while others ask the questions, Professor, could you share your experience on whether which is a ideal patient who benefits from the powered lower limb exoskeleton therapy? Would incomplete patients benefit better, incomplete spinal cord injury, or would complete patients also have separate outcome measures which improve after therapy with the exoskeleton?
Yeah, as I presented in my presentation, the motor recovery by the robot is not the, I think, major improve factor. And also, during the recovery, the helping to the cardiovascular fitness and increasing patient compliance, that is also a strong point of robot rehabilitation. So in my case, yeah, the robotics is most effective in acute or subacute stroke or spinal cord injury patient, better than chronic state of injury.
Do you also advocate some form of maintenance therapy? Because cardiovascular rehabilitation would require some form of maintenance, ongoing therapy for such patients.
Yeah. And also, we can apply that in community care center or at the house. Yeah, because we cannot send our physical therapists everywhere. So I believe robotics have a potential to expand in telemedicine or that kind of technology.
Thanks. Are there any limitations to the use of powered lower limb exoskeletons?
Yeah, the number one is cost. Yeah, cost effectiveness is a major problem. And but if we manufacture large number of machine, the manufacturing cost will be down. So I think the future of robotics is very promising.
So another question, there are some commercial models which are available, but there are some which can be used by individuals as well in their day-to-day life. What is the basic difference between the two? And also, is power, means the duration for which the power can run, a limitation with the current day exoskeletons?
Uh, yeah. Until now, those kind of integration with AI and the machine setting is not well established. So we don't know how strongly exercise should be started and how long we can apply the robotics to some condition of patient. So we need to gather more bioinformation and clinical data. And we are under those kind of step of gathering more information. And I think maybe 10 years later, we can have enough information about that. Yeah.
And have there been any studies on a combination of various strategies like brain-machine interface and exoskeletons, or spinal cord stimulation and exoskeletons?
Yeah, so maybe you all know the Neuralink by Elon Musk. Yeah, that is very interesting project. And I believe that is very promising. But maybe the main concern is the maintenance of bio machine interface. When we insert the electrode to our body, the electrode failure can happen. So if the chip into our brain broken, we cannot change those kind of electrode very easily. So I think those kind of maintenance problem will be major disturbing factor. But basically, yeah, I think those kind of project is very promising, and I hope we can have positive result from Neuralink project.
So Dr. Durgesh Pathak wants to ask, is there any evidence of use of exoskeleton in pediatric population having neurodevelopmental disorder like cerebral palsy? I know there are plenty of them available, but would want to hear directly from you. So is there any evidence for the use in pediatric population, Professor? Those having like cerebral palsy? Could you hear me, Professor Bond?
Yeah.
Yeah.
Did you ask me? I'm sorry.
Yeah,
I missed your question.
So, use of powered lower limb exoskeletons in pediatric patients, like those having cerebral palsy.
Yeah. There are many commercial angel robotics in South Korea that is made very kind of, and also, the Cosmo Robotics also have some those kind of machines, and yeah, so honestly, the rehabilitation robot for pediatrics is not satisfied. I'm not satisfied with current technology level, but
You see the potential, right?
yeah, that's right. Yeah, and also, you know, the machine is like driving a car, so we need to adapt to the machine. So, uh, compared to older people, the children have more potential to use the robotic machine more efficiently.
Right. So there is another question. What, according to you, is the optimal therapy dosing? What is the optimal dose using robotic rehabilitation? How many
Yeah,
minutes per session and how many sessions?
yeah. Based on the literature, usually most of study provide 30-minute robotic section, and usually they provide 3 times or 5 times for every week. And usually, complete session is consist of 20 or 25 session. So I also run. I also agree with those kind of dose of treatment. Yeah. So I recommend one cycle of robotic treatment consists of 50 second or 20 or 25 sessions. And but in older people, you know, sometimes forcing patient to stand more than 30 minutes, that can be dangerous. So we need to monitor the vital sign or patient condition very carefully.
So there is Neera wants to ask, are there any studies or is there any potential for having exoskeleton on a wheel frame like Segway so that mobility can be easier, right? Could you understand? You know Segway, right? So Neera wants to ask, is there any work going on such that people not only walk, they can also be on a wheel frame so that they can move faster? Are you aware of any work like this across the globe? So, like rather than walking, you move on a wheel. Yeah, this is just a hypothetical question, but I'm sure something will come sooner or later for that. Nikhil Chaudhary wants to ask, what are the potential challenges in your view, potential challenges and risks associated with integration of AI into RAGT?
Yeah, most challenging barrier is safety issues. So especially in overground robotic machines, there are some event of slip down or some patient injury in the robot in foreign country. So that's why we apply the uh, trunk support and body weight support by the suspension. Yes, so those kind of safety issue will be main concern, and except that, uh, yeah, there is no serious problem applying the rehabilitation robot, and yeah, if we gather more information or clinical indication based on clinical data, I believe we will use rehabilitation robot more widely in clinical practice.
So Dr. Mohammed Faisal wants to ask, what is the scope of this technology in elderly population?
Yes, so in elderly patients, the main effect of rehabilitation robot will be improve cardiovascular fitness, make them keeping standing position. In elderly people, usually they sit on the couch every time during the day, so they do not work. So if we use rehabilitation robot, it can substitute tilt table or those kind of rehabilitation process. So that will be the meaning of rehabilitation robot in elderly people. Yeah, that'll be different in young people.
So thank you, Professor. This has been some great presentation and great discussion. The participants may think of more questions. I know it is quite late in Korea, but if you can stay for another 20 minutes or so as we make our presentations, if by the end of it there are more questions, we'll request you to respond.
Okay. Yeah,
Right?
thank you for having me. I will stay here. Yeah.
Yeah, but if it is too late, we can understand that there is a great time difference and it must be getting late at night. So please feel free to leave if you, and we can mail the questions to you and get back to the participants subsequently also.
Yeah, thank you. And I'm also interested in your presentation. Yeah, I'll stay.
No, but fine. Ours is only a very new experience, and but would still want to share our a small experience in this field with all the participants. But hopefully, in the next webinar, we will be there with more data and more experience, a larger experience with regard to the powered robotic lower limb exoskeleton. Can everybody see the screen? Can you see my presentation?
Oh, yes,
Yes,
it's
sir.
visible.
Right. So I am from Sri Balaji Action Medical Institute, and our team will today share our experience on powered lower limb exoskeletons. Could we request all those who are not speaking to kindly keep their devices on mute? I'll just take a minute to do that. So apologies for that. We all know that the energy consumption of legs ranks first amongst human organs and is crucial for human daily activities. Advancements in science and technology has thus driven the growing use of exoskeletons in assistance in this regard. The lower limb exoskeletons can be separated into three different categories: assistive exoskeletons, rehabilitation exoskeletons, and augmentation exoskeletons. Assistive and rehabilitation exoskeletons are designed for use on people with neurological conditions or the elderly. Now, coming to assistive exoskeletons, they focus on users that have permanently lost their mobility. They assist or replace the impaired parts of the users, allowing users to live or behave like healthy people while wearing the devices. The precise position control with electrical motors is the most common combination. Some examples of assistive exoskeletons are the Rewalk, Indigo, and Locomat. The rehabilitation exoskeletons are intended for use by patients with disabilities that can be recovered through therapy and training. Goals of these systems is to create interactions with the users to rehabilitate them so that they may eventually function normally without the device. This often uses impedance control to create resisting forces for the training. The Exoathlete 2 is primarily a rehabilitation exoskeleton. It is designed to assist individuals with mobility impairments such as those caused by spinal cord injuries, strokes, or other neurological conditions in regaining the ability to walk. So the examples could be Exoathlete, Rewalk, Exo, and Locomat Pro. Augmentation exoskeletons mainly aid healthy users. The goal of these exoskeletons is to enable performance of tasks that an able-bodied individual normally would be incapable of, or to reduce the effort required for the task, like less metabolic cost. A positive feedback or force control are often seen in this category since the device needs to follow the user's motion. Actuators with higher power density are also more common. Exolegs, Rexp, Kyogo, or C-brace are some examples. You would also have seen these being used in movies, and they seem like fiction, but it is coming into reality now. Now, unpowered or passive and powered or active lower limb skeletons. What do we mean by them? Unpowered or passive exoskeletons require the user to perform the movement. Passive exoskeletons only support the body by means of mechanical components such as springs or elastic straps and rely on kinetic energy and human strength. Powered or active lower limb exoskeletons, on the other hand, use an external power source, primarily the motor or the hydraulics, to assist the user. Hybrid systems combine both active and passive elements. So the target population, as mentioned in the literature, could be spinal cord injury, stroke, cerebral palsy, Parkinson's, multiple sclerosis, traumatic brain injury, geriatric patients, and post-orthopedic surgery rehabilitation, as was also mentioned by Professor, like after hip replacement surgery. The therapeutic benefits of the passive mode exoskeletons are to reduce strain on specific body parts during repetitive or physically demanding tasks, to provide postural support for prolonged standing or awkward positions, and to enhance ergonomic efficiency, reducing the risk of musculoskeletal injuries. For the active mode exoskeletons, the rehabilitation benefits include assistance in gait training and neuromuscular re-education, enabling precise, controlled movement patterns for motor recovery, and providing feedback to enhance motor learning in patients with neurological impairments, and facilitation of early mobilization in patients with spinal cord injuries or strokes. The augmentation benefits include enhancement of strength and endurance for heavy lifting or prolonged physical activity, reduction of fatigue and injury risks in industrial or military settings, and improvement of the efficiency of repetitive tasks by reducing physical effort. Assistance benefits include enablement of the paraplegic individuals to stand, walk, or climb stairs, to provide mobility support for individuals with limited physical function, and other dynamic adjustment to different terrains and movement speeds. So the long-term use of lower limb extremity robotics can lead to increased strength in lower extremity, improved posture, increase in bone density, decreased pain, decreased spasticity, and improved endurance. There are psychological considerations also. Motivation and engagement are immensely important to a patient's success and positive outcomes when it comes to the incorporation of technology within therapy. There are few studies that have investigated the effect of using robotic devices for lower extremity rehabilitation on patient mood or motivation. Some studies have found that patients have a positive view of incorporating robotic exoskeleton within rehabilitation. The market potential of exoskeletons is great. Global exoskeleton market is anticipated to reach a significant size of 3,340 billion USDs, expanding at a growth rate of 46.2% by 2026. Now, coming to the Indian scenario, even though powered lower limb exoskeletons have been available in the Indian market since the last decade, its use has been popularized only in the recent past. We recently purchased the advanced version of powered active exoskeleton, the Exoathlete 2. So, it has a main body, a tablet PC, and a smart crutch, and then there is a movable suspension also. And the length can be adjusted according to the patient's body size. Patients can train themselves by combining smart clutch, and we will soon the team will also present cases which will make this very evident. Just wanted to brief you about the differences between the Exoathlete 1 and Exoathlete 2. So, other than the certification, the manual ankle angle adjustment makes the enhanced user's convenience. There is a button type power button. There is a charge remaining LED indicator on the product, and the manual ankle angle adjustment can be done, which again enhances users' convenience. Thigh size adjustment can be done through a one-touch cam lever tightening. Shank size adjustment touch also can be done by a one-touch cam lever tightening. And the pelvis width adjustment type can be done by 10 mm. It reduces the user's wearing time. Again, Exoathlete 1 is a passive assist mode only, whereas Exoathlete 2 is a hybrid model with passive and active mode both. So this increases the user's indications, the active mode for brain disease like stroke and passive mode for spinal cord injury patients. Now, the training data display, you can have a visual graph, mode and time that also enhances the user's motivation and could work like a biofeedback also if we can show that constantly to the patient. So, our experience, we have used it for various indications as mentioned here. Only 11 patients so far have taken the exoskeleton based gait training because we recently purchased it. There we have had some share of complications, mainly patients, some of them complained of discomfort because of tight fit, compromise over skin integrity, and a technical error that we were made aware of. So the outcomes, there have been improved gait parameters, strength and endurance, postural control and balance, prevention of secondary complications. The functional outcomes have also improved with the increased independence and improved mobility, and psychological and social outcomes with mental health benefits and social integration have been there. So patients have had a positive perception about recovery. Motivation and hopefulness has been there. Improved confidence has been there, and the initial device comfort and orientation took some time as per the patient. So we have one of the users. Please let me know if you can't hear the audio.
So he's not audible.
Not audible. Let me come back to it later. If I would want to integrate the audio again, the same problem that was faced earlier. So, limitations and challenges, of course, in not only in the Indian community but globally, the high costs have been a challenge. lack of high clinical evidence for patient improvement, and the need for standardized measures for therapy protocol and assessment. Means there's a lot of research still to be done with controlled studies done so that we can actually measure the importance of this. Insurance coverage in our country is also a challenge, and accessibility challenges in healthcare facility and public spaces further limit the practical use of exoskeletons. So, as Professor mentioned, AI would come largely in the future. Soft robotics would be integrated, and hopefully, brain computer interfaces would also be integrated. So, there are quite a few studies on this important technology that we have. So, but to conclude, robotic lower limb exoskeletons are revolutionizing the lives of people with mobility impairments. These wearable devices provide support and assistance, allowing individuals to walk, stand, and even run again. They offer hope for greater independence, improved quality of life, and a brighter future. In fact, the video, if you were able to listen to that, the user mainly talks about one. We found that previously he was not regular with his rehabilitation sessions, and ever since we have started this, he has been coming every day without fail for the rehabilitation sessions. It has given him the zeal to work, the motivation to work further, and he has a brighter outlook. And of course, we feel that he has a better outcome with the therapy anyway. So, there could be enhanced mobility, improved quality of life. It has a great rehabilitation potential, and there are tremendous future possibilities. We know that AI needs to be taken with a pinch of salt, but it is not something that we can shirk away from. It has a great potential. Tomorrow, we are sure that technology with AI will show better results than technology without integration of AI. And here comes the importance of collecting data, because AI will work only with data and will improve only with data. So the call to action is to support research, advocacy for accessibility, and to spread awareness. Friend, let's work together to create a future where everyone can move freely and reach their full potential. So imagine this chronic spinal cord injured person who is now returning to rehabilitation with full zeal, and there are hundreds and thousands of other individuals who can benefit from this technology. We will take the questions only after our team presents the cases. So once they have presented the cases, we should be taking the questions from you in this regard. So we will have first Dr. Ankush Gera. He will be making a case presentation. Over to you, Ankush.
Thank you, sir. So my screen visible to all?
Yeah, please make it in PowerPoint mode. Yeah, thank you.
Good evening, everyone. So I'll be presenting a case study on overground gait training using wearable robotic lower limb exoskeleton. So currently there are a lot of rehabilitation strategies in the neuro rehab, taking it from body weight supported treadmill training, virtual reality, electrical stimulation, and biofeedback. But exoskeleton wearable robotic for rehabilitation, this has been received a lot of attention over the several decades, which we have been listening since past 1 hour. And it facilitates early mobilization even in patients who are unable to maintain the upright position, which enables them to stand and walk regardless of the severity of involvement. Basically, this exoskeleton assisted gait training, it provides repetitive, high intensity and high dose practices compared to the traditional rehabilitation, and promotes neuroplasticity. So the aim of this case study was to evaluate the impact of overground gait training using wearable robotic lower limb exoskeleton in person with the locomotor difficulty. So coming to the case description, this case is about a 62-year-old male weighing about 82 kgs who presented to the OPT with complaints of sudden and rapid onset of weakness in bilateral upper and lower limb, 1 month back with bowel and bladder involvement, and he had difficulty in getting out of bed. After all the investigation, the diagnosis of cervical myelomalacia with Guillain-Barré syndrome was made, and after the Asia charting, it was found to be a C7 level of injury, non-traumatic, with Asia impairment scale D category. Coming to the physical therapy diagnosis for this patient, it was a generalized weakness and sensory deficit due to cervical myelomalacia and GPS, which results into the impaired mobility, reduced balance, and dependency in activities of daily living. So these are the basic settings for the exo-athlete model which we are using. So we had to take the measurements of the patient, and then we had to adjust the shank length, thigh length, foot size according to the need of the patient. And after that, we have some options for movement setting in that, where we have to select with the tablet provided along with the robo. We can make the patient stand up, we can make the patient sit down. We can also make the patient do marching at a particular place, and obviously the patient can have the walk forward. In walk forward, we have different parameters, whereas first mode is step by step, where the therapist presses the button every time and then the patient takes the step forward. But in continuous mode, once the mode is on, the robot takes the move on its own without the assistance of the therapist. And the advancement in these modes are the active and the assist mode, where the patient can actively initiate the movement without the help of the exoskeleton, but then further assistance is being provided by the exoskeleton only. And then in smart assist mode, actually the robo itself assesses the ability of the person with 20 steps and then provides the feedback and assistance based on its own assessment. So there, just patient needs to be assessed with 20 steps, and rest of the work is being done by the robot or by the exoskeleton only. So coming to the exoskeleton protocol for this particular patient, which was given along with the conventional rehabilitation, it was completely a tailor-made protocol for this patient. So for week 1 and 2, we made the patient sit to stand, and we made him adapted to the body verticalization position, because when the patient presented to us, he was completely bedridden and he was not even able to take the turn on the bed also. So this all was being done initially with suspension in passive mode, as the patient had no power. Subsequently, the patient was being trained for the standing balance, and he was taught weight shifting from side to side, anterior, posterior, and medial lateral. And then the walk in place, which is the marching, basically, the step-by-step mode was initiated for this patient in a passive mode only, which was progressed to the continuous mode. Coming to the further week 2 and 3 rehab protocol, again, after the walk-in place, which is the marching, we started the patient making walk using the step-by-step mode, and which was progressed to the continuous mode. And once, since I said it was a tailor-made protocol, once we saw some strength coming in the lower limb, we started putting a patient on the active mode, where the patient was supposed to just actively initiate the movement. So again, with that active mode, we started with walk in place, which is marching, which with each leg, and then we subsequently progress the patient to the walking. And then there we can set the threshold as the the strength increases over the time. So we started with the threshold of 1 on each leg, and the maximum we could reach to the threshold for the after the third week was 3 threshold for the right limb and 5 threshold for the left. And subsequently, the patient was progressed to the crutch walking with the exoskeleton. I'll be showing the video that will be more clear. Okay, so the dosage for this particular patient was 40 minutes a day. The whole program was given, which excludes the donning and doffing time. And it was given for 6 days a week for total of 3 weeks, constituting about 720 minutes. So these are the few videos. That's how we made the patient walk. The patient is with the suspension, and we're using the step-by-step mode. Basically, this is the walk forward mode. So the patient is walking, either by the step-by-step mode or by the active initiation. That was actually the progression of the patient. We started with the step by and the passive mode, and as the strength started recovering, we put the patient in the active mode. And this is how the patient is walking using the crutches. So basically, this is a progression of even the suspension was removed from the patient, and the patient could relate more it functionally. Okay, now coming to the results. Comparing the grades of manual muscle testings for right lower limb, there was significant improvement after the third week where the L3 myotome improved from 1 to 5. And there was more significant improvement in other myotomes also, like L4 improved from 1 to 5 and L5 improved from 3 to 5. There was significant improvement in all the muscles, even for the right lower limb and for the left lower limb also. Again, both recovered differently. That's why we had to keep the threshold different for both the limbs. And now coming to the comparison of function in sitting test score, basically this assesses the sitting balance of the patient. So where the patient had 0 score at the baseline, it improved to the 88% after the 3 weeks of this intervention along with the conventional rehabilitation. And it reached to 53 from 49 after the third week. So which was a great improvement, that is 88%. Now coming to the comparison of scores of trunk control measurement scale, basically it measures the control of the trunk. So for sitting balance, there was 90% improvement seen after the second week from 0 to 18, but there was no further improvement from second to the third week. There was a progressive improvement in selective motor control, which improved 60% from the baseline to the second week, and which further improved to the 30% from the second week to the week 3. And dynamic reaching also improved from the baseline to the second and the third week. It was a significant improvement. Coming to the comparison of 6-minute walk test distance, I told you initially the patient was not even able to take turn on bed. So he started moving using the rollator after the 2 weeks, and he was able to cover 44 meters in 6 minutes. And he was able to cover even more distance, which is improvement in 172%. That is, he was able to move 120 meter of distance in 6 minutes after the 3 weeks of the whole rehabilitation protocol. And these are the videos of the patient. That's how the patient is moving using the rollators, where the patient was not even able to stand and turn. This is after the 3 weeks of the intervention. Okay. And yes, this was a big achievement that the patient could stand independently on the parallel bar, and even he could take few more steps on the parallel bar. Okay, now coming to the comparison of quality of life, since the patient started walking within the 3 weeks from the completely bedridden condition, so he was very satisfied with the satisfaction with life as a whole was great from 0 to 8, and he was satisfied with his physical health, mental health, and the social life, and he had some hope that he would be able to engage himself in the society. So coming to the discussion, so there was significant improvement was seen in trunk control, sitting balance, walking capacity, and quality of life after overground exoskeleton gait training using the wearable robotic lower limb exoskeleton, along with the conventional rehabilitation. These findings are consistent with the study being done by Zhang et al. In 2022, where 60 minutes of overground exoskeleton gait training for 2 to 3 times a week for 4 weeks, it showed significant improvement in gait performance, balance, muscle strength, psychological state, and satisfaction with the rehabilitation. So coming to the conclusion, I would conclude that this technology in conjunction with the conventional rehabilitation, this may be considered an effective and functional way to explore and promote neuroplasticity in persons with locomotor disability due to spinal cord impairment or any other impairment to improve strength, lower limb function, and quality of life. And yes, if started early and intensively, it may show significant improvement. Thank you. Any questions?
Great, Ankush. We'll come to the questions after Sanpreet makes his presentation. Very nice presentation. And could you unshare your screen? Would request Dr. Sanpreet Singh to make the next presentation on the other case.
Can everyone see my slide?
Yeah, please make it to PowerPoint mode.
Okay.
Thank you.
So a very good evening to everyone. So I'm going to present a case study on gait training using powered robotic exoskeleton for a person with spinal cord injury. So I myself, Sanpreet Singh, an occupational therapist from Swami Shri Balaji Action Medical Institute. So the purpose of the current case study is to evaluate the overall effectiveness of lower limb exoskeleton-based gait training in individual with spinal cord injury. So coming to the case overview, there's a patient of 31-year-old male who had a fall from terrace followed by sudden loss of power in bilateral lower limb and bowel and bladder function. Further on, he was diagnosed with spinal cord injury, complete T12 paraplegia with AIS-A classification. The date of injury was 29th of January 2022. The height of the male was 1.78 meter. The weight of the male was 80.6 kg and the BMI was 25.4 kg per meter square. So this was the clinical background of the patient. So the first surgery was happened in 29th of January 2022, which was D9 to ilium decompression and posterior fixation. And then after the surgery, the patient was on conventional rehabilitation, which is from April 2022 to November 2024. And in November to December, the patient was introduced to powered robotic exoskeleton along with conventional rehabilitation. So these were the impairment of the patient. Like you can see on the right side, these were the lower extremity muscle motor score for the Asia in INSKI. So the power for left and right hip flexors muscles are 1 and 3, and for knee extensors are 2 and 2. For bilateral upper limb power was 5 out of 5. Sensory was absent for both light touch and pinprick. Below the L3, PAS and VAC was absent. So the patient presents with complete paraplegia, weakness in lower limb, trunk, sensory abnormalities are there, neuropathic pain were there, balance and mobility impairments were there. So here the little description about the device, as we have already covered in the previous presentation. So we have a model of ExoAthlete 2. As you can see, the device and the suspension and the exo crutches, smart exo crutches. So for the clinical outcomes, for the clinical evaluation, we have used the ICF model, which was for the body function and structure domain. We have used the INSKI lower extremity muscle score. For activity limitation, we have used outcome measures like fist, function in sitting test, trunk control measurement scale, spinal cord independence measure, third version, walking index for spinal cord injury, second version, and 6-minute walk test. And for the participation impairment, we have used the ISCOS spinal cord injury quality of life dataset. So this was the intervention. As you can see on the right side, a flow chart or a principle on which our intervention was based, like powered robotic exoskeleton will stimulate a normal gait pattern, which will further boost the neuroplasticity along with motor relearning. And then this synergistic effect, when combined with conventional training, will further lead to functional independence in the patient. So prior to enrollment, a written clearance was provided. The participant underwent measurements of body weight and height. Skin was also double checked for any marks of redness prior to enrollment immediately after each training session, so that we can protect against any development of pressure source from exoskeleton training. Moreover, his primary caregivers were instructed to provide any immediate feedback about any changes in his skin coloration. So this was our rehabilitation program cum intervention, which was happened in a 3-phase structure. Like for the phase 1, the orientation and device calibration was done, in which the patient was made to sit on the exoskeleton for multiple times and introduced with different parameters or different modes of the exoskeleton. In phase 2, there is assistive gait training, and in phase 3, the independent or minimal assistance gait training, in which the patient was introduced with the smart exocrutches, so that a more realistic pattern of gait training was done. So the dosage of the intervention was like, it was of total 4 weeks. Frequency was like 5 sessions per week, concluding total 15 sessions, which exclude the phase 1. Time duration was 45 minutes per day, and followed by conventional rehabilitation, including occupational therapy sessions and physiotherapy sessions, like balance training, strengthening exercise for upper limb, lower limb, stretching exercises. So rehabilitation goals were to enhance the mobility of the patient, to improve functional independence, and to address secondary complications in a chronic case, like to prevent osteoporosis or improve cardiovascular health. So these were the videos or the pictures from the phase 1. On the left side, you can see the video in which the patient was made to sit, and correct positioning of the verticalization of the patient was done, so that the patient gets familiar to the device for the first time. On the right side, you can see the pictures from the front side and the lateral side of the exoskeleton when the patient was sitting with the exoskeleton. So these were the videos from phase 2, which is assisted gait training. So in the first video, you can see the patient was doing active initiated mode, walk in place, which is marching with a safety harness. And the second video, you can see the walking forward mode, in which the patient was doing walking with active initiated mode with a safety harness. So in that phase, we have to be considered, we have the most important factor to be considered during the exoskeletal training, that the user must shift the center of gravity, that is COG, anterolaterally, so that the patient or the therapist can initiate stepping. The subject has to find his home balance, which is position that is shifted slightly forward to balance the shift in the center of gravity. So this was a picture from the phase 3, which is week 3 to 4, when the patient was introduced with crutches, smart crutches, so that he gets familiar. As you can see on the left side, multiple assistance was required during the initial week of the phase 3. And on the right side, you can see the patient was even able to manage his upright position even without smart crutches at the end of the intervention. So these are the videos from phase 3, which is week 3 to 4, when the minimal assistance gait training was done. On the left side, as you can see, the patient was able to move with active initiated mode with the use of smart crutches. So these were the continuous walking sessions with smart exo crutches. On the right side, the patient became more stable as the progression of the sessions was done. Like he is able to maintain the 4-point gait of reciprocating gait with exo crutches. So at the end of the session, at the end of the intervention, which is at session 15, the patient exhibit the more stable gait pattern as compared to the previous sessions of the walking forward mode. So at that time, the threshold of the patient was at the threshold of the exoskeleton was set as for the right, it was 4, and for the left, it was 7. So these were the results. As the pre-post comparison of Asia scale for lower extremity motor score, there is slight improvement for the left and right hip flexors, as it changes from 1 to 2, and for the left hip flexor it changes from 3 to 4, and the rest of the things were same, like sensory was absent below 3, and PS and VAC was absent as it was before the intervention. As now coming to the pre-post comparison of trunk control measurement scale, as you can see, it measures the trunk control in 3 different domains, like static sitting balance, dynamic sitting balance, and dynamic reaching. For static sitting, it from the baseline, like it was 7, it has reached to the 10. For dynamic sitting, at baseline it was 7 and increases to 10. And for dynamic reaching, at the baseline it was 4, and post intervention it was 6. So the total trunk control measurement scores pre-intervention was 18 out of 58, which increases to 26 out of 58, which which says that the trunk control of the patient has improved after the intervention. So this is the pre-post comparison of function in sitting test. Like pre-intervention, the score for fist was 30 out of 56, and post-intervention, it reaches to 40 out of 56. So to evaluate the functionality, we've used the SCIM3. So the subdomain of the SCIM3, like mobility, it increases from 10 to 15. So after the intervention, we also did the 6-minute walk test to evaluate how much distance patient can cover using KFO-based reciprocating gait training. So at the baseline, the patient was able to cover only 8 meters of distance with KFO using rollator. At session 6, he was able to cover 21 meters of distance with the help of rollator, and at the session 15, like after intervention, it reaches up to 45 meters, which is a very significant difference that can be considered after this intervention. So these are the videos when the patient was doing a rollator based KFO along with KFO gait training. So at the session 6, at session 6, as you can see, the patient had a difficulty in finding his balance while using rollator. So at the end of the intervention, the speed of the patient increases. Speed of the gait increases. Step length increases. Patient finds less difficulty during the ambulation. So after exoskeleton gait training, participant was able to maintain his upright posture exhibiting. As you can see on the left side, this was a picture from pre-intervention when the patient was not able to maintain his upright posture while standing with KFOs. And on the right side, at the end of the intervention, he was able to maintain his upright posture, which exhibits that he has improved trunk balance and lower limb stability. So the walking index for spinal cord injury is basically a functionality-based functional capacity scale, which measures improvement in ambulation in SCI patients by evaluating the amount of physical assistance, braces, and device required to walk 10 meters. On the left side, before interventions, the level assigned to the patient was 3. That means the patient was able to move at parallel bars less than 10 meters using long leg braces with minimum to moderate assistance of 2%. And on the right side, you can see the post-intervention scores. The level assigned to the patient was 6. That means the patient was able to walk with the help of rolling platform walker using long leg braces with minimum to moderate assistance of 1 to 2%, and the patient feels slightly comfortable. So to evaluate the quality of life, we have used the International Spinal Cord Injury Quality of Life dataset. So you can see there is a significant improvement in his perception to his psychological health. So these were the words of the patient, that he says, "My psychological health has improved notably. My mental well-being is better than ever because I finally feel hopeful, motivated, and wants to put more efforts and a kind of satisfied with my life again after the robotic sessions, after the robotic gait training." So to evaluate the acceptability of this new technology, we have used TAM questionnaire, which is technology accessibility model questionnaire. So in this, we have asked the patient 7 questions based on comfortability of this new technology, how much painful he has felt during the intervention, how much fatigue levels were there, is the therapy sessions were enjoyable, advantages, and how much he is intended to use in future, and would he recommend this to the other patients as well? So this graph shows that there is a significant positive feedback from the patient according to this questionnaire. So this is very interesting, as we have already covered in the previous presentation of Chhabra sir, that the introduction of robotic gait training significantly improved the patient's attendance and engagement in rehabilitation sessions. So on the left side, while the pre-training session was marked by the blue bars, which is irregular participation, the consistent attendance during the post-training phase highlights the motivational and functional benefits of integrating this cutting-edge advanced technology into the rehabilitation process. So this is very interesting findings in this case study. So these were the parameters. Here we have the different parameters throughout the 15 sessions where the spinal cord injury patient used the exoskeleton, like how much time spent in different modes, like passive mode, which is step-by-step mode, walk in place mode, and active initiated walking forward mode. So there an increase in time spent in active initiated mode during different phases when the patient actively initiated the movement during the ambulation. So this was the video at the end of the intervention when the patient was voluntarily trying to do a sit to stand. So as you can see here, in this patient was voluntarily trying to do a sit to stand without calipers. So this video shows that how much positive impact of robotic exoskeleton gait training can put on the patient's psychological health. And the patient trying to, at the end of the video, as you can see, the patient is trying to lock his knee as well, putting weight on this lower limb. So this is also significant finding in this case presentation. So these were the few patient-reported adverse events, as he had said, like minor step marks on skin were found, feeling of claustrophobic, basically a discomfort while donning of the exoskeleton in phase 1, a sense of nausea after a session. Patient reported a sense of nausea after a session, and musculoskeletal strain on upper limbs during the phase 2. So now coming to the discussion, like for clinical implications, the overground robotic exoskeleton may provide a structured approach to improve mobility, balance, and functional independence in SCI patients. Notable improvements in key measures, including trunk control measurement scale, function sitting, and WSKI-2 scores, indicating a better trunk control and sitting balance and ambulation when overground exoskeleton-based gait training is combined with conventional rehabilitation. For patient engagement, we could say a regular attendance during the robotic training phase highlights the motivational impact of this technology-integrated rehabilitation programs. Psychosocial benefits are there, including improved mental well-being and life satisfaction. Challenges encountered, that initial adaptation to the exoskeleton required a very close supervision and training. Minor skin irritation and fatigue during early session underscored that the importance of safety monitoring and patient education are required. So in conclusion, we can say that robotic overground exoskeleton-based training may represent a significant step forward in bridging the gap between conventional therapy and advanced technology, offering a very new hope for functional recovery and independence in individuals with spinal cord injury patients. So these are the references. Thank you.
Thank you, Sanpreet, for a great presentation. We are running out of time, but we'll take some quick questions for Professor Sanjay Vaughan or for any of the presentations which may be there. Professor, there is one question from Dr. Nekram Upadhyay. How does this device affect secondary health conditions associated with spinal cord injury, such as pressure sores, muscle atrophy, or bone density loss? So does it have an effect in reducing pressure source muscle atrophy or bone density loss? My understanding would be, Nikram, that at least our experience is a short follow-up. I think with long-term use, you are aware that it would definitely prevent muscle atrophy. It would prevent osteoporosis, and pressure sore incidence would also reduce as the patient can be mobilized better, and with this the tissue viability also increases. I think Professor Sun would agree with that, right?
Yeah. I also agree with that. And during the machine running, we should very cautious about muscle sore and skin abrasion on the foot and knee joint and so on. And basically, I agree it can have a positive effect to BMD, bone density, and prevent osteoporosis.
Now, Ankush or Sanpreet, you could take this question. What are the safety protocols in place to ensure the user does not get injured while using an exoskeleton?
It is completely safe to be used as the suspension harness is there. Moreover, we make the patient learn how to balance over that, and the therapist, the caregiver, whosoever is operating the exoskeleton, he's being trained well. Moreover, all the ranges being performed are within the physiological and anatomical joint range, so there's no risk of pulling the muscle or any fall. It's completely safe to use.
Professor Sun, are there any technical failures which have been reported in literature with the use of the exoskeleton?
In my knowledge, there has been no that kind of technical failure. Yeah. The robotherapy is a kind of very safe and promising treatment, I think.
So,
The best part about this technology is that if anything goes wrong from the robotic point of view, it senses that and it stops the movement there and then only. So it doesn't take the joint into extreme ranges. So it's comparatively safer to use.
Right. And yeah, Professor.
Yeah, can I have one question to Dr. Samprit?
Right.
And is there any improvement in the range of motion in hip joint or knee joint of the patient? Did you check the range of motion? Yeah.
We did not check the range of motion, but still, if we check as the hip flexor muscle strength has increased, so likewise, there should be increase in range of motion as well. But we did not check it.
Yes. And I think there can be the result of the improvement of range of motion in the hip and knee joint. Yeah, that can be one possible region of improvement, I think. Yeah, thank you for your nice presentation.
Yeah, that would be especially also in cases, chronic cases, a chronic case like the one presented by Sanpreet, right? Because he was already 2 years with a spinal cord injury. Now, Sanpreet, how much does this rehabilitation cost for a hemiplegic stroke patient? That's one of the questions. So could you throw some light on that?
How much, if we say in INR, like for a 1 month session, for a 1 month rehabilitation package, including conventional therapy along with this technology-based robotic session, so it will cost around 1 lakh approximately.
Right.
For 26 sessions.
So, it would be costing, say, around 60% more than conventional therapy, right?
Yes.
Right. So, if there are any other questions, quick questions, you may please address them quickly. It's very late for our Korean colleagues, and we would want to wrap up the session.
Good evening.
Good evening.
Sir, I'm Dr. Binish again from Hamsa.
Right.
About leg fatigue, I think Sanpreet had mentioned in his this thing observation. Which scale did you use? Leg fatigue, how was it assessed? I would just like to know that.
So leg fatigue was not assessed by any clinical outcome measure. We have just reported it according to the patient feedback.
Oh, on a visual analog scale kind of stuff, huh?
Yes, we can say that.
Yes, fine. Thank you.
Good evening, sir. Myself, Dr. Durgesh Pathak. I am working in neuro rehab at Janakpuri Super Specialty Hospital, Government of NCT of Delhi. I have one common question from Dr. Ankush and Dr. Sanpreet as well. Both of them, they spoke about the dosiometry. I think Dr. Ankush said that he used 40 minutes for each session, and while Dr. Sanpreet has said that 45 minutes for each session. I just would like to know, so how did you decide that dosiometry? Did you take any reference from like any literature, or
yes,
you have
definitely.
decided
Yes, definitely. The recent systematic review on the clinical effectiveness of this overground exoskeleton-based training. So they have mentioned two intents of the study, like for functional restoration and for cardiovascular rehabilitation. So they said that for functional restoration, the dosage parameters are quite shorter than for cardiovascular rehabilitation. Like it ranges from 3 weeks to 50 weeks. And for time, if I would say for time duration, it says like from 30 minutes from 45 minutes to 60 minutes. And for the number of session per week, it says around 3 weeks three session per week to 6 session per week. So there is a very wide range the literature has supported. So that's why our dosages varies according to the case study.
In my
Thank you so
case, as explained by the sir, that there's a whole range of dosage being available in the literature. So I tried to cover the 720 hours, which is the optimum dosage when I read the literature that different people have tried to cover, 3 days a week for 4 weeks, for 6 weeks. Since I had only 3 weeks for this particular case to be done, so I tried to achieve the intensity as much as I could, comfortably and, feasibly. So that was the hit and trial kind of thing for me, which directly or indirectly I tried keeping it with reference to the literature only. So I tried to kept it in terms of hours. So it was the overall dosage which mattered in my case.
Yeah, but
Thank you.
I think Professor Son, would you agree that we still need to do more studies on what would be the optimum dose, and we need to that still is one of the limitations that we are not aware about the optimal dose per se.
Yeah, I agree that we don't know what is the optimal dose, but most popular dose is 30 minutes and 20 session a month. And if possible, I agree we should use higher dose as much as possible.
And we would need to individualize that to each patient also, customize it depending on the stage, what stage is the patient after the acute event, and what is the fitness level of the patient. So the fatigue is something that you would want to avoid in such patients and gradually build up on it, right? Dr. Komal Kamra wants to ask Sanpreet and Ankush, did you try with the patient turning during ambulation, and was this effective?
Yes,
This is
because in
very
6-minute walk test, the patient is supposed to cover distance of 15 meters. So there, every time the turns comes, every time the patient walks. So the patient was able to take turn, although using the rollator. But if we would have, used it a little more, so there must have been some great progression in that also.
Right.
Sir, one more question. I just would like to know, sir, what's your take of using the exoskeleton in the patient who are having like sensory deficit paresthesia over the extremities?
So, like Sanpreet demonstrated the case, he was a complete spinal cord injury, and I think sensations below L3 were not there, right, Sanpreet?
yes, sir.
So So it has been used in complete injuries as well. And the only thing we need to take care is to prevent that we do not test the tissue viability and pressure sores are prevented. So that needs to be taken care of.
Thank you, sir.
So if I think with this, we have no other questions in the chat box. We'd want to thank Professor Son and, of course, our colleagues from the company for providing us the opportunity to have a wonderful webinar today. It was a great presentation. It was great discussion. I would also want to thank Sanpreet and Ankush for great presentations. And of course, we would want to thank all the participants who have joined us today in this chilly evening as well. Friends, we have the Spinal Cord Society webinars every month, and you keep in touch and see which webinar. We'll let you know soon the webinar for next month. But we will also get back to you with more experiences with powered lower limb exoskeletons. And as our experience increases, we will get back to you with long-term follow-ups of such patients as well. So thanking you all. I hope we can see quite a few comments in the chat box that people that all of you were satisfied with today's webinar and found the presentations appropriate. So thank you, everyone, and look forward to seeing you again. Good night. Thanks especially to our Korean colleagues for staying in touch and being there through the webinar, even at this late hour in Korea. Thank you very much. Thank you.
Yeah. Thank you. Have a nice day.
Thank you. Thank you. You too. Happy
Thank you,
New
sir.
Year to everyone. Happy New Year.